For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 37. Our updated look at cirrhosis and what people are thinking about it today starts now.
This week on Surfing the NASH Tsunami.
But it's bottom line fact that patients progress from pre-cirrhosis to cirrhosis and to decompensation, which is about 1 of 5 patients in 48 weeks in that population. And as such, I think this is clearly the population with the highest unmet need.
Let me ask all three of you from your 3 different perspectives. Where is the next breakthrough in terms of understanding how to help cirrhosis patients likely to come from? Is it likely to be a clinical trial that works, or a more practical way to use diagnostics for patients living with the disease today, or better testing methods to figure out faster what drugs do? Where do you see the next breakthrough?
And it's not only picked up by MRE. I mean, there are blood-based markers. Health has been approved as a predictive marker in patients with histologically confirmed cirrhosis, and the ELF cutoff here at the high end, 11.3, as predictive of future outcomes. So we're able to measure these patients. It's not routinely done yet, but we have to tackle that problem somehow.
We are looking right now into a portal venous resistive index like we do in the renal arteries. We look at the renal arterial resistive index, which would be a proxy for HVPG.
49% of people didn't attend ultrasound surveillance. They're high-risk patients, know they're high risk, they didn't get appointments. We got that down to 17% by engaging with the patients, making sure the data was right, their addresses were right. The system needs to be better configured to enable patients to engage.
So when you think of the other diseases associated in NASH populations, which is myocardial function and renal function, it's all measured by functional tests and not by biopsies, which I think makes perfect sense. I mean, we have GFR, we have ejection fractions, which are all functional tests. And in the liver, we just don't use that as much as we should.
We're almost talking about technology as a pincer movement. That on one flank, you've got the kinds of things that Lars is doing and that Scott and Neil were talking about 2 weeks ago that are very, very high-end technologies. And then at the other end, if we have all that technology in place and we can do a brilliantly good job of identifying the patients who are most at risk, we then have to communicate that information to the people who are treating them in a way that the people who are treating them are motivated, and we've got to communicate the information to the patients in the way that the patient is motivated to react.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, Antaros Medical co-founder and chief scientific officer Lars Johansson, as they discuss advances and goals in diagnosing and treating cirrhosis on Surfing the NASH Tsunami.
So it's the middle of July, for those of you who haven't noticed. Louise is actually in Bulgaria today, not in the UK. Jörn is at home in Germany, not to be confused with Southern Europe, unless you're where our guest Lars Johansson is, which is in Sweden, at which point lots of things I think look like Southern Europe. And I'm in Pennsylvania, where our temperature is relatively livable, despite the fact that everybody has more air conditioning than we know what to do with. But we'll see a high of 32 today, which Jörn, I think, puts us a few degrees below you, and Louise a few degrees more than that below UK. And Lars, did you say you got up to 31 or 32 today, or did you say today was a cooler day, but that's where it's getting to?
No, we're heading there later this week. Today it was around 20, so we're chill here.
Chill is good. Chill has a real benefit. Louise, greetings. You're in Bulgaria, right? Well, tell everybody a little bit about where you are.
Yeah, no, I'm sitting on the Black Sea coast near a city called Burgas in a nice small Bulgarian village called Ravda. Nice part of Bulgaria down towards the Turkey and Greek ends. So we get to see a lot of the passing fleet of traffic, and today we were given a display of the Romanian Navy going up the coast in a big way. And for anybody who knows that just across the Black Sea is Ukraine. There was a very forceful look of ships sailing up the Bulgarian coast in broad daylight, so very visible. It was interesting to see.
So for those of our listeners in the U.S., which is most of them, who probably know about as much about Bulgaria as I do, what makes Bulgaria special?
It's a lovely place. It's always warm and great during the summer. In the winter, you can go to the mountains and go skiing. My 2 stepchildren are half Bulgarian, so we have family links to the area, so that's why we come here. And the people are just lovely. I love Bulgaria. They're not the most vaccinated nation in the world. They're probably one of the least vaccinated populations of the world, but it's been an interesting conversation with people that we know out here. We always love coming, and we just haven't been for a couple of years with the pandemic, so it's nice to get back.
Welcome back. You've gotten back to Australia this year. You've gotten back to Bulgaria. I think you're doing better with your travel, aren't you?
Yeah, absolutely.
And Jörn, how are you today?
I'm good, Roger. It's 7:30 in the evening, so temperatures are coming down. We're still at 33 Celsius at this time. Tomorrow, I think, is going to exceed that temperature, so rough days in this part of the world. We're not quite used to the heat.
As we were saying before we came on, Americans are spoiled because we have more conditioning than we know what to do with or necessarily merit, unless you're in the state of Texas right now, where it was hot enough last week that they browned out and things like that. Lars, greetings again. Where are you today?
Oh, I'm back home in Sweden. Came home yesterday. Been touring Berlin and Prague. Went with my son to a soccer tournament in Prague, and just came back to start a new soccer tournament in Gothenburg. So it's that's what this summer is about. I think we have 4 soccer cups that we are attending.
How old is your son?
13. Well, that's the youngest one.
Well, it's a great age. You can play all day at that age, can't you?
Yeah.
Injuries don't set in yet.
And they have unlimited energy, right? They got to run this all off.
They have unlimited energy, absolutely, and I wish I had too.
Yeah, it doesn't work that way, sadly. You know how to use all that stuff. You just don't have it. I'm a little older than you. It doesn't get better, but it's fine. It's all fine. So I guess that's the end of everybody's weather and temperature and where we are today. And what we're going to be talking about today is cirrhosis. We had an episode last summer on cirrhosis that was extremely well received. We've come back to it a couple of times since then with different casts of characters. And there was a cirrhosis late breaker with semaglutide at ILC a couple of weeks ago, which Jörn is an author. And one of the many one-on-one conversations Lars and I have had that for technical reasons have not made it onto this program was actually about some of the things that he is doing and they are developing to study and evaluate cirrhosis. So I think this should be a fascinating conversation, and I'm excited to listen. Louise and I have decided we know how to ask questions, and that's probably all we need to do. So with that, why don't we just go to Groundbreaker? One good thing, let's do professional. One good thing that happened in the last week.
Professional, I was going to say something personal, because I was introduced to a little girl that loves dinosaurs and does some sort of exploration and experiments with them. So it's an opera, it's a movie on Amazon, I guess. Dina Dana, I was just telling you about it, Roger, and my girls love it. The thing I like about it, she asks questions about dinosaurs, and then she says, I have to go and do an experiment about it and find out something. So that kind of attracted me as a clinician and researcher. My girls are asking questions. Oh, that girl is, and maybe they adapt a little bit to that. So we'll see where this takes us.
Okay. So it's personal, but you're doing career planning for your kids, huh?
Well, you should, I guess, never do that as a parent, but I guess I like the questioning part of it.
It's a good skill to develop. Okay, next.
Mine will be personal because I'm on holiday, so I'm not doing anything professional this week. Well, I am doing this and a few other things, but nothing too stressful. And it was getting out of the country before the heat wave.
Well timed and strong work. Okay, Lars, you're up.
Yeah, I think professionally, it's always exciting when you get new data to dig into. So we finally got our 2-year follow-up data on renal imaging, natural history in patients with NAFLD, looking at the decline using imaging. So we're digging into that. So that's exciting.
Professionally, tomorrow we are recording our proof of concept CME episode, which will have to do with non-invasive testing. And our guests will be Jörn and Mazen Nuruddin and Quentin Anstey and Lena Allen. And we will be putting a promo on it on LinkedIn and some other places. If you're a listener to this podcast, well, if you're listening to this, you're a listener to this podcast. If you're listening to this podcast, I would love for you to listen and give us your feedback on it, because we're doing a couple of novel things. You don't see a lot of CME done by podcast. In fact, virtually none. And we're using a qualifying technique for how to get continuing education credits called nudge questioning. It's based on the behavioral economics concept called nudge that won its creator a Nobel Prize in economics. And the basic idea is, instead of asking people to answer factual questions, ask them to reflect on how what they're learning might change how they look at the world or what they do. And the hope is that, therefore, you produce a better learning experience and a more thoughtful set of responses. Please join us. As I say, we'll be talking about it on LinkedIn and a couple of other places and giving people links that you need to give us your email address because we are tracking exactly who participates and we will have questions and follow-up. But we'd love to have you with us. I have other good professional things, but I think that's one good place to stop. I think we first started talking about cirrhosis on this podcast. Manal Abdelmalek started talking, Louise, a year and a half ago maybe at this point, fairly early on, about the whole question of how do you treat cirrhotics with what do we have available today. I think that was part of our wrap-up in 2020 was her conversation on that. Idea being that unlike folks with earlier stage fibrosis, where if we have drugs coming, that's exciting, patients who are cirrhotic are on a faster track to a far more negative outcome. And therefore, the question is, what can we do now? And what are we trying to achieve? So Manal Abdelmalek started by talking about the use of older drugs, where the goal would be simply to arrest progression. If we could keep people with compensated cirrhosis stable until the drugs in trial to treat cirrhosis are approved and become available, that would be a real win for patients and for providers alike. Since then, on this podcast, we've discussed agents whose earlier stage trial results in regressing fibrosis and perhaps even supporting cirrhotic patients appear promising. We've talked about what the goals in therapy should be when treating cirrhotic patients in the current environment. And Lars and I have talked in a series of one-on-one conversations and interviews that never made their way onto the podcast due to technical challenges about some of the tools and analyses Antaros and others are starting to apply to assess the impact of interventions on cirrhotic patients in terms of looking at the liver volume, spleen volume, HVPG, and analogous ways to get at that kind of data that are an important part of figuring out exactly what's working for cirrhotic patients and what do they need. The goal is for this conversation to be at an intersection of what do we know about drugs, you aren't taking the lead on that, and what do we know about devices, and where are we making progress in terms of evaluating cirrhosis, both for clinical trial and for actual treatment purposes. Lars taking the lead on that. And with all that, Jörn, why don't you come on off mute and let's kick in.
Sure, Roger. And I was just trying to think back to Manal's comment, which are fascinating. In the absence of effective therapies in the field of NASH cirrhosis, we're falling back to some old substances. And we should revisit that ourselves because there's some data, also historic data, that statins and metformin are of use in this patient population. But if I take a step back and think about all my patients I'm seeing in clinics, the ones where there's always the biggest surprise that they haven't been identified before is the ones that come back from a liver biopsy with the F4 category in a lab where you wouldn't have suspected cirrhosis in the first place. And both the patients and the physicians are shocked because compensated cirrhosis at an early stage is something that's not easily picked up. If I talk to my colleagues, cirrhosis, they are thinking of tense ascites, complications, bleeding. That's, of course, the worst of this advanced disease stage. But so many people are in early stages that are undergoing regular medical care and nobody identifies them. And so from all the data that we know on the natural history of cirrhosis and the rate of complications, to me, this is the group with the highest unmet need because their line to reach endpoints is the shortest. I know we've mentioned some of the negative clinical trial data here in F3 and F4 patients. That's where the famous 20% rule comes from. Now, maybe that's a little over-exaggerated because it's a highly enriched population, but it's bottom line fact that patients progress from pre-cirrhosis to cirrhosis and to decompensation, which is about 1 of 5 patients in 48 weeks in that population. And as such, I think this is clearly the population with the highest unmet. Now, you mentioned pharmacotherapeutical intervention. Data that we presented at EASL this year was accepted as a late breaker, oral, the first late breaker in that session. And Rohit Lumba took the podium to present our data. And it was a 48-week intervention using the GLP-1 analog semaglutide in patients with very compensated early cirrhosis. And while we did not achieve a regression of histological cirrhosis category, you could improve a lot of metabolic markers, and there was a good safety signature. And as such, I think this is very informative and reassuring. You can safely use drugs that improve metabolism in these patients. And again, revisiting the concept of which patients I'm worried about most is the ones that are not identified yet and are in early stage cirrhosis because they're going to have a big impact on their life in 1 out of 5 cases within the next 1 or 2 years, progressing to end stage, significant loss in quality of life, and complications, potentially even mortality. And as such, I'm really happy we're revisiting this here. I think there's a lot of unmet needs in that population. I mentioned identification of these patients, screening strategies. There's There's no standardized screening strategies across most medical areas. No, if we're revisiting the type 2 diabetes patients, for sure now there are some measures in place, but I think in clinical practice, a lot of these patients are still being overlooked.
Yeah, thanks, Frank. I think that all makes really good sense as a starting place. As I was listening to you, one of the things I was reflecting on is the work that Alina Allen's been doing with MRE that takes a look at MRE results, the KPA levels being able to predict the probability of decompensation over a 3-year period in people with compensated cirrhosis. If I remember correctly, with KPA 5 it was 20, and with KPA 8 it was 40%. But a significant way to be able to understand exactly how much risk patients are at in a way that I think can be executed, if not everywhere in the world, certainly in many hospitals and some other settings.
Yes, and it's not only picked up by MRE. I mean, there are blood-based markers, the ELF, for example, and based on the data on the progression to cirrhosis and endpoints, ELF has been approved as a predictive marker in patients with histologically confirmed cirrhosis, and the ELF cutoff here at the high end, 11.3, is predictive of future outcomes. So we're able to measure these patients. It's not routinely done yet, but we have to tackle that problem. Somehow MRE, and Alina presented great data. She's in a much better position to tell you about the details of that again, but also some blood-based markers are linked. And revisiting EASL, we saw so many abstracts that are linking the high FIB4 category, which is F3 and F4, to outcomes, even beyond liver outcomes. So again, I think this is where we really, if we want to change something, can do it most easy.
So Lars, please share your thoughts.
One question to Jörn to start with. I'm just curious on your thoughts on the SEMA data, which Rohit presented, where we actually participated as well. Do you think that there is a chance that drugs like SEMA or others, even though you don't see a regression in fibrosis, actually inhibit progression? Because that could still alter the faith of these patients, I guess. I mean, what's your thoughts on that?
Yeah, I think it was a very straightforward study that aimed at the regulatory endpoints, improvement of fibrosis by one stage, and the study was negative. It was actually a pretty high placebo response rate, which exceeded the number of patients in the SEMA group. So a negative study, but it showed a very favorable effect on the endpoints that SEMA has been shown to have a benefit on: improvement in A1C, weight loss, and also a decrease in transaminases for whatever that is good for. But I would say that, yes, it was safe. It has benefit for the patient. It was a negative study in terms of the primary endpoint. You cannot reverse cirrhosis in that time frame studied. But this is where I think your expertise and knowledge comes in, because I'd like to understand what changes in these patients. And there are early signs of portal hypertension that might be reversed. We've been seeing some data on spleen and liver size. I'm sure blood volume could be measured and assessed, and I know the two of us discussed this previously, and I'd be very much interested to learn how that was affected in this type of trial. Bottom line for me, I think it might take a little longer to actually show regression of cirrhosis, but even if they stabilize those patients, that would be a benefit in terms of using these type of drugs.
Yeah, I agree. And I think we don't know, obviously, if it inhibits progression or not, but I think there could be early signs that we could look at, like the subclinical signs of portal hypertension. I mean, these patients, typically, if you look at these, they don't suffer from splenomegaly, but they have increased spleen volumes. That's what we've seen. We see that they're typically in the order, if you go from an F1, you see increased spleen volumes of 20-30%. Now, to call it splenomegaly, you need to go to, it's pretty much like 3 times the normal spleen before we call it splenomegaly. So it's 300% increase. But as we go up, we see very clear increases in spleen volumes and as signs of early increase in portal pressure. And if you can show that you're reducing that, and you most likely have done something good to the patient, but exactly how that translates into future events, we don't know yet. It's still too early to say, but it's definitely indicative of an improved situation on portal pressure, but it could also be reduced inflammation that hasn't yet translated into reduction in fibrosis. Some of the studies done with the bypass, they show it takes many, many years to regress fibrosis. So in a metabolic situation, such as, or improvement such as you get with the GLP-1s, you may not see regression in fibrosis in that time frame.
So question to Lars and Jörn, and Louise actually, short of regressing fibrosis, what are the measures that you could look at that would tell you whether we're having a better effect for the patient? What were we looking to stabilize? And are there actually metrics that you might hope to reverse even before you saw regression in fibrosis that would tell you that the patient's quality of life or prospects for long-term health were better?
Here are my thoughts. As I mentioned, in the SEMA4 trial, there was a lot of improvement in metabolic parameters, which are beneficial for the patients. But you're thinking of liver endpoints and liver benefits. So one of the measures that's clearly been linked to outcome and that has also been accepted as surrogate for drug approval by the regulators is HVPG, which assesses portal hypertension. And Lars, you mentioned this as something that could be non-invasively assessed. My understanding and knowledge, it has not been valid. So any non-invasive technique has been validated to meet HVPG, to correlate with it. But if we improve early signs of portal hypertension, improve portal or decrease portal pressure, even in the area where it's not clinical significant portal hypertension yet, and that's, when we're approaching end-stage disease and talking about very serious bleeding, ascites, even if we improve portal pressure in that preclinical stage, I'm convinced this is a benefit for the patient. As you rightfully said, I think it's a combination of both metabolically driven inflammation and the amount of collagen in the liver and the remodeling that's been going on. With MR technologies, and maybe you can educate us again, what's the current state of the art in that context that could be used to assess we could be simply talking liver size, but also blood flow to and from the liver, and these aspects should be translating into benefit for the patient and as far as I understand this disease.
I agree with you, Jörn, and I think the good thing is that this patient population in the compensated cirrhosis is still not that bad in terms of other effects. I mean, you don't see all the retrograde flow that you can see in the decompensated. You don't have so much scarring in the spleen. So some of these surrogate endpoints still work in this early stage of cirrhosis. And that's why I think we still see the plasticity of the spleen being there, meaning that it can be used as a surrogate. Blood flow for sure. We are looking right now into portal venous resistive index like we do in the renal arteries. We look at the renal arterial resistive index, which would be a proxy for HVPG. So that's the ongoing work we're doing right now. But of course, we don't have outcome data on these yet. And that's another study which we are setting up, which is a big longitudinal study to really follow these patients over time. In the discussions I've been involved with the authorities, it's also been very clear that if you want to go into late stage portal hypertension, they will not accept anything else than HVPG for a phase 2B, and then obviously outcome for a phase 3. So I think that's where we are right now. But if you're looking for signs of improving the condition for the patients, I think there are multiple things we can look at, like the spleen volume, the blood flow, and then the more advanced, if your drug is actually turning down stellate cell activity. But that's not for the broad studies because it's too complicated, but it will give you an indication whether you're actually turning down stellate cell activation, which we also can start to look at. But that's with PET, not with MRI. So it's not scalable to large clinical trials.
That is very interesting, and I know Roger has something to say about that because we've had Neil Henderson and Scott Friedman on here regularly detailing on some of the technologies that could be used to turn off stellate cells. Before I hand it over to Roger, I wanted to reflect on, your study you're setting up with long-term outcome. You remember, if you have compensated cirrhosis or you're looking at the population like the simtuzumab trial that were negative from Gilead, you have a relevant event rate, and you might not need that long outcome study to show in these patients that your diagnostic test in a advanced population is linked to clinical outcomes.
That's a good point. And that's why I also think it's really interesting to see what is happening, even though we may take away the driver, but I'm coming back to the semaglutide data, which you mentioned again, because it could be that we just turn down activation of hepatic stellate cells, but it doesn't mean it doesn't translate into reduction of fibrosis for years, but it could also mean that you stabilize the condition. And being able to measure that, I think, would be extremely helpful, because I'm sure we've done something good for the patients if we even just stabilize the disease. Because the other work that we're involved with, and there are data, it's still probably 6 to 12 months away before we see the first intervention data, is on the looking with the gadoxetic acid or gadoxetate to look at hepatic or liver function with imaging. So we're looking into hepatocyte function to really see what is the amount of functioning hepatocytes available in the liver, which which have very strong predictive value. So I think there will be data coming out, intervention data, in the next probably 6 to 12 months, I hope.
So, Lars, a really naive question about that. Is there any reason that data should produce better or worse in a cirrhotic, say, a compensated cirrhotic patient than somebody with F2 or F3 fibrosis? Or we're really looking at the same thing? It's just a question of what your baseline is and where you are in the disease.
I think the data on that technique is actually all coming from compensated and decompensated cirrhosis. So there's not that much data in the early stage fibrosis. I would actually turn the question around and say we don't know how well it performs in early stage fibrosis.
It's interesting because when you are quoted on this podcast in your absence, it is most frequently the comment you made about how much of what we do looking at the liver is looking at what shouldn't be there or isn't working as compared to what we should do, which is looking at what is working and how well. So when you start talking about stellate cell activation or deactivation, I think then you're getting really at the heart of the issue, right? Which is, so what's supposed to be going on here?
And you know, it's interesting just when you think of the other diseases associated in NASH populations, which is myocardial function and renal function. It's all measured by functional tests and not by biopsies, which I think makes perfect sense. I mean, we have GFR, we have ejection fractions, which are all functional tests. And in the liver, we just don't use that as much as we should, I think, because it will tell you about the functional reserve.
And there are some functional tests that have been used and studied in the liver field. Some are propagated from the US. Some are used by surgeons to actually plan their resective capacities. But they're variable. And in context of staging the liver disease, they haven't really given us the information we'd wanted. I think the HepaQuant test is probably the one that's most advanced, in particular in the cirrhotic population, well established. There are some other tests like LIMAX that use certain labeled compounds, acetaminophen, being metabolized in the liver, and the correlation with liver function and liver size is there, but it's not helping that much in terms of assessing the disease stage in terms of what's relevant for NASH quite yet. And I think the technologies you've been mentioning, they're more, they have a higher granularity and could potentially pick up more subtle aspects of the disease.
I agree, and I think we still have to see and obviously look at the outcome, but I think it's just interesting that because the disease is defined by biopsy, we're stuck on it. Like, I mean, CKD is defined by GFR and heart failure is defined by ejection fraction. They are all defined by functional measures rather than biopsies, and that's of course why the acceptance of using them is so much higher.
Yeah, and if you look at what's changed in this field in the last 3 years, I think it's heading in that direction, right? We're not so focused on what do you have to do to get fibrosis level down anymore. We're really a lot more focused on how does the liver work and what are the things that we can measure on the way there. So let me ask all three of you from your three different perspectives, where is the next breakthrough in terms of understanding how to help cirrhosis patients likely to come from? Is it likely to be a clinical trial that works or a more practical way to use diagnostics for patients living with the disease today, or better testing methods to figure out faster what drugs do? Where do you see the next breakthrough?
I'm going to jump in here because I'm going to link it back to what Jörn was saying at the very beginning. And it's the patients who present with biopsy F4 that we didn't know and we haven't detected, and they've been in healthcare for a number of years. So I'd like to see the breakthrough come in the better diagnostics and pickup of patients within hospital systems. Now, whether that's adding a FIB4 to every score that's done through a phlebotomy system to pick up the highest risks in healthcare. We've heard the comment regularly that diabetes and endocrine don't see cirrhosis in their populations and primary care. So we've also at Barcelona had John Dillon talking about ILFT, where they run these diagnostics to pick up the highest risks. But even with well-engaged primary care physicians in hospitals, only 50% of that group actually responded to the abnormalities. That's where we need to target. We're getting better diagnostics. We're moving the needle on that, but we're still presenting late. We're still not picking up patients that have been in healthcare for a long time. That's where patients always feel frustrated, but I've been told not to worry. I've had multiple tests. It was never picked up, or somebody told me I had an abnormal test 20 years ago. So there is a level of frustration from the patient population, not only the medical and nursing communities, in this late stage diagnosis. So early diagnostics and better markers, FIB4, ELF, as routine may well be something that we could utilize to pick up these patients.
I'm vaguely remembering a data point that says that 50% of all cirrhosis patients find out they have cirrhosis for the first time on a random visit picked up for another reason and did not even know they had liver disease before that. I think that's the right number. So that that in and of itself, as Louise points out, becomes a huge problem. Is it a problem we have the potential to do something about currently? Or what do you think's got to happen for us to get there?
Yeah, I think you asked about therapeutics, Roger. I think we have to get there. We have to identify these patients, and we have to provide solutions, diagnostic solutions, and care pathways, or let's say provide some risk stratification approaches in terms of who do we want to scan for suspected compensated cirrhosis in what a treating physician has never thought of. So I think at that point it leaves the rationale of the physician ordering a test, because they would never suspect cirrhosis in their patients. And we need something that's automated, as been just mentioned a little bit earlier with the ILFTs or electronic healthcare record mining by an artificial intelligence algorithm. But even then, and I'm going to say this again here, the study we've done, or that colleagues of mine from Mainz have done together with some other Germans, was the SEAL program, where we used a test to identify patients that are likely to have advanced disease, and half of them never showed up for their follow-up appointment. So we're not transmitting the information well enough, even with the imperfect tests we have today, or maybe because of the imperfect tests. So I think at multiple levels we have to improve diagnostic performance, we have to remind physicians to test for this, or have something do this automatically, and then link these patients to care. So it's all about the referral pathways here again, I think.
Now we're back in Barcelona, right? Louise just mentioned John Dillon. We are back in Barcelona. Because, I mean, the science is really elegant, right? It was 2 weeks ago that we had Scott and Neil on talking about different things that they were finding that could be done that were all way over my head, Jörn. So you honor me when you say Roger can talk about this because he remembers. I remember vaguely the conversation, but the science was something I could follow, but not something I could articulate. Let me ask Lars. Lars, what have you seen recently in the basic science research that gives you encouragement about where we can make better or faster breakthroughs or do a better job of understanding how to identify and help patients? And by the way, the answer could be nothing, but I'm guessing that's not it.
I think it's also my background is in atherosclerosis originally 25 years ago. It's a very slowly progressing disease. And the way you do it is in the early stage of drug development, and you identify patients and you look at treatment response by a combination of data, imaging, circulating biomarkers, what have you. And then in the end, to have something that really will help you here, it has to be really simple and relatively cheap. It can't be too expensive. So I don't think in the end that you will have a very expensive imaging test for every patient here. It has to be feasible. But what I do think is that we can use the combination of imaging and circulating biomarkers to really identify those circulating biomarkers that will predict patients' outcome. That in combination within the large outcome trials being done right now, because they are collecting in some of them lots of data, biobanking material that we can go back and mine and look at outcome and prediction. So I think all these big trials currently being done is actually, whether they are positive or not, will still help in driving the identification of the best biomarkers for risk prediction. So I think the studies itself, that they will help us whether they are positive or not.
I think there's one point that when we talk about the studies, when we talk about these outcomes, what we're looking at is systems that have been very nicely designed. They have proper support, they have proper interventions, they have nursing resources, they have administration resources. The one thing that is always obstructive to the care that I found in patients with cirrhosis is the hospital systems aren't configured to do that. Only 25% of letters that went out for appointments didn't make it to patients. So therefore you've got rid of 25% of the people who didn't know they had an appointment in the first place. We introduced nurse calls and checking for patients on cirrhosis who came for ultrasounds, for example. 49% of people didn't attend ultrasound surveillance. They're high-risk patients, know they're high risk, they didn't get appointments. We got that down to 17% by engaging with the patients, making sure the data was right, their addresses were right. The system needs to be better configured to enable patients to engage. It also needs to be enabled and configured appropriately for us to implement all of the dynamic work that's going going on to be delivered to patients and their care. Because if the system doesn't work where it should, phone numbers are wrong, emails are wrong, patients have moved, letters don't get there, we have a problem. We cannot keep these patients in. They lose the ability to be followed up, and we lose that contact, and trust breaks down because you're not available. These are fundamental issues that are so big that everybody just believes they work, and they don't. And they're really obstructive to the care that we're designing now.
So, Louise, is that entirely a human systems issue, do you think? Or would better technology or better diagnostics help motivate either the treating providers to be more aggressive in dealing with patients, or patients to hear something and respond more favorably?
If you can get your patients into the service because the letters go out, the appropriate information is given, and you can engage, then they will buy into absolutely everything that helps them. But I don't think it's a UK system problem. I think when I worked in Australia, it was slightly better. It's where we invest in infrastructure. There are lots of issues in hospitals and health providers where the infrastructure is the weakness, not the technologies, not our ability to design trials with all of the infrastructure supported, but it's when we try and roll it out. And patients, like Jörn was saying, they get lost in the system or they don't understand it, but it's not because for the majority of them it comes from their problems. It's the fact that the systems don't necessarily all work properly. We forget those basic things we expect to be perfect aren't. But patients really do want this new technology. They want to feel better. And I think one of the measurements that we can use when we look at these groups of patients is how they feel, how they function, how they survive. Is it improving as we stabilize their disease? And those outcomes are really, really important to patients. They've said time after time, we want to be stabilized. We want to feel better. Not feeling worse is an outcome. And they will go to the ends of the earth to get that, and they will provide their data. They give their biopsy tissues. They're really, really engaged. Looking at the fundamentals of how our systems in all areas work together is a potential benefit to getting better outcomes and retaining patients, and also locating the right patients.
So, Jörn, it strikes me listening to Louise and to Lars that we're almost talking about technology as a pincer movement. That on one flank, you've got the kinds of things that Lars is doing and that Scott and Neil were talking about 2 weeks ago that are very, very high-end technologies at getting a much better understanding of exactly where intervention needs to be and what interventions help you. And then at the other end, you've got the kinds of things that you and Jeff put the meeting in Barcelona together to do, and that John Dillon talked about and Louise talks about all the time, which is if we have all that technology in place and we can do a brilliantly good job of identifying the patients who are most at risk, we then have to communicate that information to the people who are treating them in a way that the people who are treating them are motivated, and we've got to communicate the information to the patients in the way that the patient is motivated to react. Those feel to me, the way we're talking about it today and frequently do, like two completely different processes. Is that how it feels to you too, or do you see a point of intersection between them, or points of intersection?
I agree that there is a big disparity of the technology, the state-of-the-art technology that is available in high-end technologies in science and clinical trials versus the way we set up clinics. I mean, I do get mails sometimes that, our phone line is all jammed, that they can't get through to schedule an appointment. And you'd always think, how can that be? There's a person concerned about liver health and they don't seem to come through over a phone line. In the end, they give up and don't come to our clinic. So reflecting on that, I think there's certain limitations in everyday clinical care where you cannot apply these type of high-end technologies. And it would be so important, as Louise rightfully said, to empower the patient and give them the information to do something and change something for them, because this is also going to be at a much lower price in the end. If they change lifestyle, they know where they are going to benefit the system. So I think we should invest on certain healthcare structures here, yes, to improve that. On the other hand, end of the spectrum, I do think we need technology advances. It's very different in systems across Europe even. I would have thought that in the UK you have a certain referral system that's somewhat automated and it might support, but for example, in my clinical system, it would need an active, either the patient asking for a referral and reminding his physicians to finally refer him, or somebody to do so based based on a test that he thinks this is needed for. So there's lots of avenues to improve everyday clinical care for these patients.
And then on Lars, I'm thinking that if you go out to the other end of the spectrum where you live, that advances are significant and considerable and being made on an ongoing basis. They translate well into drug development. I'm not sure I understand how they might over time translate into patient care, because it isn't something we touch on a lot when you and I talk. But I'm wondering what thoughts you might have about that.
I think the way it translates into patient care is that you actually may make the right decisions on what drugs to advance and not early on, because we better understand if the drugs have the effect that we think they have, if they turn down cell selectivity, if they have antifibrotic effects. And if we can see that early, we will not be wasting time trying to develop the wrong drugs. And also, exposing patients to something which we could have known didn't work. So I think that's how these advanced technologies translate. But moving into the clinical practice, it has to be simple and affordable. Coming back again to my background in athro, 20 years ago when I was with AstraZeneca, we did a huge study trying to get acceptance for APO, A1B instead of LDL. And people suddenly they were used to LDL being like bad cholesterol. And this was a fantastic study showing improved risk prediction and everything. But it just couldn't transform because it was just, we don't want another, people understood what LDL meant. High LDL is bad for you. So even though the risk prediction was better and everything, in the end, it didn't fly simply because it's such an enormous task to educate the population. That's something to keep in mind here. It has to be simple and affordable and still do the job.
So Quentin Anstey always talks about not letting the perfect be the enemy of the good. I think that's kind of what I hear you commenting on.
Yeah, no, if it's good and it translates, that's what we need. These fancy techniques that I'm working with will help us make the right decisions in drug development, but it's not, I think, for the masses.
So for the non-masses, or for the people who worry about the masses, I think one of the things our audience would like to know are one or two things that you're working on right now that you believe will be extremely promising in terms of pushing the frontier in terms of knowledge around, as you point out, doing better drug development faster or having a greater understanding of the disease. Tell us about a couple of things you're working on right now, please, that you think have the potential to do that.
Well, I think one of these is obviously the comorbidities we see in cirrhosis. But also I think that just the ability and where we're running trials where we know a lot of cirrhosis patients actually end up with renal events. So we look into what is happening in the same studies as we investigate the liver, we investigate the kidney, or we investigate the heart. The HFpEF situation in NASH patients is quite, it's well known, it's there. So I think to me, it's really a race. I mean, it could be manifested in the liver, but it could also have endpoints in the heart or in the kidneys. And I think we can do a much better job in understanding a more holistic view here than we have in the past. And that's, I think, where we right now spend a lot of time on, looking a little broader outside the liver, but in NASH patients, also muscle, etc.
So here comes my question to Lars, if I may, Roger. There's a lot of imaging studies or imaging tests ordered in clinic every day, MR and CT. And my question is, from the technologies that you're looking at, is there anything that we can do to transform these standard imagings that are being done for, let's say, back pain or something, to actually identify patients with suspected advanced liver disease? Just by having the sequence run, and CT might be more suitable because you have a more broader overview without needing a specific sequence. But, it's a simple thing like nodularity of the liver, and to describe that and train radiologists to do so.
No, I completely agree with you, Jörn. And that's actually, we're right now running, I think, a very interesting project. It's a population-based study where we did liver CT in 30,000 Swedes, and we collect outcome and we measure liver fat, but also all these other things, and using AI-based tool. So you can deploy it into any CT where you have a piece of the liver involved. So there's some work ongoing in this direction. And I agree with you. I think CT is better suited. It's worse suited from a technical perspective because it doesn't contain as much information as MRI, but it's done on a much larger scale and it's much simpler. So I completely agree with you, Jörn. I think there is definitely room for improvements there, that you just send your test and say, this is a high risk patient with high risk of liver disease. And I think CT would probably be the easiest way or the best way to go here.
Yeah, interesting. And I think my experience is that even if they pick up hepatic steatosis, so that's not the question of the exam, it might not be reported. So I think this comes back to education again.
Yeah. No, we actually already published the baseline data from those 30,000 subjects from CT data, looking at the liver steatosis, but now we're also mining it for other effects on to see if we can find fibrosis. And we're not collecting biopsies in this study, but we are getting the outcome. So I think that's really helpful.
Yeah, that's the future. We don't want biopsies, we want outcomes. Congratulations.
If you can get directly to outcomes, obviously that's a huge step in the right direction and also makes it a lot more serviceable for patients in day-to-day care. Louise, you've made great contributions and then you've gone back on mute. So why don't you, if you have anything you want to share, why don't you, as we get towards the bottom of the hour, why don't you come on out and share?
I agree with everything the guys have said. All of these techniques are fantastic. They're marvelous. But if you can't get the patient to the appointment because the letter doesn't get there, we miss the opportunities. So we do still have to look at how we get to those patients, how we communicate better, how we look at the basic systems that in some respects obstruct our ability to use all of this great technology or cost effective. If it takes 2 or 3 appointments to get you to your CT because you don't get the information, that's 3 times the cost to get the one test. It's blocked the other slots. So it is a big resource. All of it is very exciting. We're getting closer and closer to the best diagnostics, but we're still failing to get the right people to those diagnostics. So we need to pinch some movement, as I think you said a little bit earlier, but we need to remember the fundamental part of what we do is trying to get people there. We tend to focus a little bit on the high-end range technologies, but we need to get those people detected in the best way, but we need to make sure that they're there, and we're struggling at that end a little bit more than we probably should do, and that's where I'd like to see health systems better engaged, because we can start to provide the education if we can get to those patients to get to this high-end technology and better outcomes earlier and look at how these drugs work in them.
So you would think that on a per capita basis, that's lower investment, but it's harder to find the people who are going to make it. Because you're investing in higher-end technology, people know how they're going to get their money back out of their investment, and you can get private investors to do that. When you're talking about doing a better job of getting phone calls returned or creating greater throughput within healthcare systems, then the spend is lower, but the people willing to spend the money and having the will to do what they've got to do to get it right just might not be quite so self-evident. Jörn, was that? I thought I saw you nodding while I was talking. Was that what you were nodding at?
Yeah, I am thinking of these everyday hurdles where we lose patients at all different levels of the track, and this would be to just apply the number of tests that we have now and have a consequent follow-up of patients. That's a hurdle, but the implementation of new technologies will help us here. I think that's my take of this conversation part.
All right, so we're kind of at the bottom. We are at the bottom of the hour. So let me ask a question kind of on the way to wrapping up, which is, this conversation is a little bit like a Rashomon and to say that we each touch the system in very different places, all 4 of us. So I'm wondering if each of us could talk about one place where we touch the system, where we see an exciting opportunity for progress and what it is, and then a place where someone else is touching the system, something that's not exactly what we do every day, but where we're also excited about the potential for progress. Brave one, go first.
I'll be brave. I suppose on the areas where I touch the system or where the system touches me, it's very much that engagement with the patients to get them through the door and to get the best test at the right patient for the right time. And the area that I think is undermined, is we have touched on it, is this whole inability to put a receptionist into something that at a small cost because somebody's fighting for that type of money, whereas you just get a few DNAs or did not attend to a CT scan and MRI, you'd have covered the salary for that month or the 2 months and multiple patients times over. So it's where we see the funding going in is not necessarily in the right place. That excites me because if we get that right, we get people to these right tests. For me, looking at the volume of the liver, looking at the volume of the spleen, that does excite me. We see patients report right upper quadrant pain with normal liver enzymes who feel better as pressures come down. So they report the changes, and measuring those is important. So that area excites me, but we need to be able to get to the right patient at the right test at the right time. And sometimes we're trying to jump hurdles to do that. And we've got great tests coming. We've got some good tests that could be used better if we can get the right patient, the right test at the right time.
So I've been thinking a lot about how I could educate my peers on liver disease and identifying those compensated cirrhotic patients, starting with primary care physicians, but in particular the endocrinologists or the radiologists. As I posed my questions to Lars, do a CT scan, identify a nodular liver, but do not describe this because this was not the question of the scan. And while I do not want to imply not good practice here, I think it's something that happens. We're very focused on certain, we've called it siloed in the past, certain aspects. I think I'd like to see advancements in terms of, let's say, recognition of dangerous signals by either automated algorithms, technologies, spin-off things like Lars has developed. And I agree with him that the technologies they're looking at are in the drug development space. But I think if you slim them down, if you take version 0.1 of that and you can implement it into a clinical setting, you'll probably still gain knowledge and be able to risk stratify better. And as such, I think the advancement in that arena would be very exciting to me.
Yeah, I think we touched upon it before. I think actually some of what I'm very excited about is the larger scale trials and the ability to pool data, because there is so much that is measured, and to dig out the best, simplest, affordable tests with best risk prediction. I think that's an area we will see a lot of development in the coming years. And obviously it requires collaboration between companies. I mean, you can pool baseline data and you can pool placebo group data to really dig out this. I think it's a great resource for development of these affordable tests for these patients, which has to be, you need it, and they can't be too complicated. That's my take on that.
So Lars, my mind went in two directions, and one of them was exactly the one you just articulated. And the other one was something very different, which is that if one of the real challenges we have right now is figuring out how to educate the healthcare system on how to identify, manage, and treat patients better, the way that tends to get solved is drugs get approved. And when drugs get approved, investment money comes in, right? I mean, Stephen was talking about that last week in the context of if you actually get, if Regenerate 2 means that you might actually get OCA and resmetirom to the market by the end of 2023, that will just open the gates to all kinds of education to everybody in the entire process, patients, advocates, providers, nurses, doctors, specialists, everyone, that we will have the effect of dialing up salience and moving matters more top of mind, and then it'll be easier for everyone to do the right thing and know what they're supposed to do. Lars, the real augment that I see coming out of work like yours, you said this before, if we could find a simple way to go back to the basic science, things like this is something that turns down fibrogenic activity, or this is something that turns down a stellate cell, or whatever, in a simple way that we could educate people on what that meant and why, then I think you'd have all your pieces in place. You'd have the funds to educate, you'd have the motivation to educate, you'd have an understanding on the part of people that we can do something to help patients, and then you'd have a simple way to start to articulate the basic science around it. Louise, that would be my version of the patient-centric pincer movement, if you will, as compared to the commercially-centric pincer movement.
I agree.
And with that, let me thank everybody. I don't know how the technologies can come out on this. We've had a couple challenges on our way through, but that's why we call him Magic Mike Wilson, because his job is to make magic at moments like this. So, and Lars, we have a note, which is that the next time we have you on, start in the room that you wound up in, not in the room you started in. Because when you move from room 1 to room 2, night and day in terms of what we were able to hear from you.
I ended up in my kitchen, actually.
Well, there you go. And what that means is you can prepare yourself a snack when you're done, or and that'll be perfect.
I better not.
Okay. Thank you, everybody. Thanks for joining us. Thanks for bearing with the technology. Congratulations in advance to Mike on the fantastic work he's about to do to turn this into a real-life episode. We will not see Louise next week. She's going to be taking a week of vacation in Bulgaria, so we'll see her in 2 weeks. We'll see Jörn next week. Lars, we'll see you sooner than we have now that we know exactly how to hear you, even if it's in the kitchen. And we will be back next week. Let me put in a plug for everyone to look for the promo on the CME episode, because we want your feedback on that, and we want to see how that goes. And we'll be back with another episode of Surfing NASH next week. I'll be back with the business report in a few minutes. Everybody say goodbye.
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 Thank you, folks.
And now for the Season 3, Episode 37 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes.
To start, a sad personal note.
I want to start today with a sad item. On Sunday, our colleague and media strategist Steve Ennin lost his father. I don't have many details about this. I'll share more when I know more, probably next week. For now, if you count yourself a friend or fan of the podcast, particularly if you've ever lost a parent yourself, please hold Steve and his family in your hearts. And with that, back to business. Last week's episode, reviewing the July 7th Intercept Pharmaceuticals press release on the updated Regenerate data and analysis, played a role in a couple of record-breaking download stories here at NASH Tsunami. Those stories will be the lead business item, heck, the only business item in this week's business report.
Download highlight number 1, a new 2-week record.
Until this week, the largest number of downloads we had ever seen over a 2-week period was 3,391, the second and third weeks of January this year. The second largest number was 3,343 the weeks of May 17th and 24th. So, it's a big deal to report that with 30 hours left in our reporting week, which runs Wednesday morning until Tuesday night, our total for the last 2 weeks stands at 4,208. Let's put it this way, we're already 24% ahead of our best 2 weeks ever, and we've got 30 hours left.
Download highlight number 2. Smashing the 2K barrier 2 weeks in a row.
Until the last 2 weeks, the only time this podcast ever went over 2,000 downloads in a 7-day period was the week after NASH Tag 2023 when we hit 2,157. The last 2 weeks in a row each went over 2,000 downloads. Last week was 2,073. As I write this week is already 2,135. By midnight Eastern U.S. time tomorrow night, this will almost certainly be the largest single week ever.
Analyzing the vault suggests 4 reasons for these successes.
4 reasons. 1. The last 4 weeks have seen ILC 2022 and its 2-week follow-up, and then Regenerate. These are big, important issues. No surprise we saw a lot of downloads. 2. Another reason for the story involves the fact that our distribution during ILC 2022 left something to be desired, including the Wednesday we didn't drop an episode at all. So, those 2 weeks were 2 of our weakest weeks of the year, which makes sense that this would now be 2 very strong weeks, although maybe not this strong. Third reason, which should be no surprise to listeners, involves not only having great stories to tell, but having great people to tell these stories. The Regular Surfers, our semi-regular co-founder and superstar Steven, Scott Friedman, Neil Henderson, Maza Nuruddin, Michelle Long, Rachel Zayas, all great guests that you folks respond to really favorably. We're lucky to have folks like this come and join us. The fourth reason is the thing that happens sometimes after big events. New people find us, and each of them downloads a boatload of episodes. Last week, every conversation or episode we released in the last 2 months received at least 8 downloads, and all but 4, that would make 52 out of 56, had at least 10. We've never seen a streak like that before, and frankly, I doubt we'll see 2K more downloads this week, although with the stage whisper, let me add, hey, surprise me. And with that, I'm off. This is a major content week for Magic Mike, who has this to do and then the CME proof of concept tomorrow on his plate. Just for kicks, recording today had multiple transmission challenges, so he not only has too much to do in not enough time, but none of it's easy. Also, I want to thank Eric, Steve, and Murph for everything they do. This week in particular, I want to wish Steve and Murph peace and light as they deal with the loss in their family. And as always, thanks to all of you for making this such a worthwhile labor to pursue, and really a thing of love. Stay safe, surf on. Look forward to seeing you on the podcast next week. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.